Welcome to our second class, and it's HSC 530, Children with Developmental Disabilities. What we're going to cover today is some of the basis of the heredity of genetics, which for many of you it's going to be a review. But because it's the basis of so many of the developmental disabilities that we talk about, it's good to have the basic understanding again. The genes are the units of heredity, and they have the instructions to make up the body's blueprint. They code for the proteins that determine almost all of our characteristics, and that's physical and behavioral. Humans have an estimated 35,000 genes, and most of those genes come in pairs. And when they don't come in pairs, we have some problems, and we'll be talking about some of those specific disabilities related to that. They're made of strands of DNA, deoxyribonucleic acid, and most of the genetic disorders are caused by one or more changes in the genetic code, the instruction code. And it causes particular genes to prevent them from functioning properly. Now, not all mutations are harmful to an organism, but most are. And there are some benefits that we get indirectly from mutations. And mutations are involved in evolution, so they are very important. But usually when we talk about a mutation, we talk about a change in the genetic coding that was harmful to an organism. The study of the genetics is on human variation, and the physical location of those genes is a locus. Now, the way I try to remember it is the genes are organized in structures called chromosomes. I think of the chromosome as a big parking deck. The physical location of the gene is the locus, and the locus is, I think of that as the parking spot. And the different versions of the genes are the alleles. And you can think of that as the different colors of the cars or the different makes. But it gives you an idea of the lineup and organization when we talk about the genetic terms. DNA is a double helix, and it's composed of three main parts. It's composed of a 5-carbon sugar, which is deoxyribose, a phosphate molecule, and one of 4 nitrogen-containing bases. For DNA, the 4 bases are adenine, guanine, cytosine, and thymine. And for the instruction codes, they're made up of different combinations of those bases. So the bases are very important, and the order of the bases is very important. The DNA is the code to produce the proteins, and obviously the proteins make up the enzymes and all the chemical reactions in our body. But before this can go on, the DNA has to be replicated, because remember, during the cell meiosis, we have to make 2 different copies of DNA. So at first it's replicated, then the instructions are transcribed into transfer RNA or tRNA, and then it's translated. And this replication, transcription, and translation is called the central dogma. Like DNA, RNA has 4 bases also, except for the thymine replaces the uracil in RNA. So if you ever see codons in a lineup for DNA as far as the different instruction code in order of the bases, if you see the T, it's a DNA strand. If you see the the U for the uracil, it's RNA. The messages encoded in the RNA is read in the 3-letter combinations of the bases, and those are called codons. And they code for specific amino acids to make up those building blocks for the proteins. And we know by the sequence that we see in the gene, it's possible to predict the codons and then the amino acid sequence and the protein that the gene makes. So more importantly, it's important that we know we can predict what it's making, but also when they're missing a specific combination of codons, we know what they're not making and what that person is going to be missing in the DNA. There's 20 possible amino acids, though most amino acids can be coded for by more than 1 codon. So there is some forgiveness in the body for alterations in the amino acid lineup. The building of the coding sequence is signaled by a start codon, and it's also signaled by stop codons. So when we think about it, so the body knows not to get into a run-on sentence. There's a yes, this is the first word of the first sentence. There's the stop codon signaling the period and the beginning of another sentence or another combination coming on. So some of the disabilities that we talk about happen because there might be a premature start codon or a premature stop codon where the body should have gone on and read the rest of the instructions, or there could be just missing codons completely. So we'll talk about some of those disabilities. And this is just a pictorial representation of an amino acid with the different codon combinations. And you can see each of the individual bases and how they make up. And again, a pictorial representation of the central dogma, which is the transcription and translation process that goes on. And there can be alterations in this process. And when you think about it, the human body is pretty finely tuned that this generally goes on without a hitch. But sometimes there can be some pretty significant alterations in the process. Now, the chromosome terminology. Humans have 23 pairs of chromosomes for a total of 46. The first 22 pairs of the chromosomes are called the autosomes. And the 23rd is the X chromosome, and it consists of either X chromosomes in females or one X and one Y chromosome in males. So again, that's the 23rd pair, and that's where we end up with the X-linked X-linked disorders, which we'll talk about quite a few of those in disabilities too. But there can be autosomal problems, and that's when we talk about that the genetics occurs on any of the chromosomes 1 through 22 of those pairs. The alleles are different forms of a gene, and they're represented by different DNA codes. Humans have 2 copies of alleles of all your autosomal genes, and you get one from your mother and one from your father. And the variation of these changes can occur in the DNA code, and that's why we have genetic variations. That's why we don't look exactly like our parents. And the different kinds of changes that can occur too that can be harmful for an organism are deletions, insertions, and duplications, and that occurs in the lineup of the base codons, as we mentioned before. And there also can be inversions of pieces of DNA also. The variants that are associated with disease or trait phenotypes are often called the mutations, and they can confer, though, a selective advantage. Remember I said before that not all mutations are harmful to an organism. One example that we frequently use is sickle cell. Carriers of a sickle cell mutation in the hemoglobin beta gene have increased resistance to malaria, and this is beneficial, and it can help explain why this mutation has been maintained in the population and has not evolved out. But in reality, in Western New York, we don't see a lot of malaria, and in the U.S. we don't. So this mutation is helpful for those with sickle cell in areas, predominantly Africa, that still have problems with malaria, but for most, the mutation is not an advantage, has no advantage, and actually can be significantly disabling. Through most natural selection, the process that drives evolutionary change notes that mutations that are advantageous for an organism, specifically a population of organisms, so because this is done over long term, it's not to the benefit of the individual, but those that are disadvantageous or harmful should be eliminated. Most often, again, they're thought of to be deleterious, meaning they cause a change in the gene function that causes disease or death or some disability in the organism itself. Now we'll talk about some of the modes of inheritance and how these diseases or conditions are transmitted in a family. And it's important for us to know this because knowledge of some of these basic Mendelian patterns can help predict the reoccurrence risk for relatives, which is something that's very commonly asked to a healthcare provider when a family finds out that they do have a child with a genetic disorder, or indeed they are carriers of a genetic disorder, to help them with some of their reproduction planning, and that they can be best informed to give the most optimal care for any children that are born with a disability. Inheritance patterns for single gene disorders are classified on whether or not they're autosomal or X-linked, so whether or not they impact the chromosomes 1 through 22 of those pairs, or if they're on the 23rd pair, which is X-linked, and whether or not they have a dominant or recessive pattern. And this is called Mendelian genetics, after the geneticist Gregor Mendel, who is the monk. So again, we want to know if they're autosomal or X-linked, and if they're dominant or recessive. In autosomal dominant inheritance, again affecting only chromosome pairs 1 through 22, Only one copy of the diseased allele is necessary for the individual to be susceptible to expressing the phenotype. So with each pregnancy, there's a 1 in 2 or a 50% chance that the offspring will inherit the diseased allele and therefore express that phenotype. Unless a new mutation or a spontaneous mutation has occurred, all affected individuals will have at least one parent who carries the diseased allele. Autosomal dominant inheritance is often called vertical inheritance because of the transmission pattern from parent to offspring. With any of the autosomal disorders, the population, the proportion of males affected should be equal to the proportion of affected females, because remember, it's affecting the autosomal chromosomes 1 through 22, not the 23rd chromosome, so there should be no difference in the gender impacting. So male-to-male transmission can be observed in autosomal dominant inheritance. Examples of some diseases with autosomal dominant inheritance include myotonic muscular dystrophy and Huntington's disease. In autosomal recessive inheritance, 2 copies of the diseased allele are required for the individual to be susceptible for expressing the phenotype. Typically, the parents of an infected individual are not infected themselves, but they are both carriers. With each pregnancy of carrier parents with autosomal recessive inheritance, there is a 1 in 4 chance, or 25%, that the offspring will inherit both copies of the diseased allele and therefore have the phenotype. There's a 1 in 2, a 50% chance that they will carry one copy of the diseased allele and be a carrier. And there's also a 1 in 4, or a 25% chance that they'll inherit no copies of the diseased allele. They won't express it as a phenotype, and they also will not be carriers. And they are not at risk of passing the disorder down to their offspring. Examples of disease processes with autosomal recessive inheritance include sickle cell and cystic fibrosis. As with autosomal dominant inheritance, the proportion of males and females affected should be the same in a given population. Now let's move on and talk about some of the disorders that impact that last chromosome, that 23rd chromosome. These are the ones that we call X-linked disorders. And the same as the autosomal, there is X-linked dominant and X-linked recessive. So the same as an autosomal, only one copy of the diseased allele on an X chromosome is required for an individual to be susceptible to that disease. Both males and females can be affected, but males are usually more susceptible and more severely affected because they only carry one copy of the gene on the chromosome, so the only copy they have is diseased and will impact them. Some of the X-linked dominant disorders actually are lethal for males. The same as autosomal recessive, X-linked recessive, 2 copies of the disease allele on the X chromosome are required for an individual to have that. Since males are hemizygous for X-linked genes because they only have the one gene, the only X chromosome, any male with one copy of an X-linked recessive disease is affected. Okay, but with the females, they would need both, and they would have to get it from each of their parents. Because of this, they're usually carriers for X-linked recessive disorders. Affected males are related through carrier females, or they're related through the mothers. For carrier females, with each pregnancy, there's a 1 in 2 or a 50% chance that her sons will inherit the disease, and a 1 in 2 or 50% chance that her daughters will be carriers for the disorder. Examples of X-linked recessive inheritance are Duchenne's muscular dystrophy and hemophilia A. Most of the disorders that we know of, though, are actually complex inheritance, or they've also been called multifactorial disorders, and they're caused by interactions or variations in multiple genes and environmental factors. The genes involved may make the person susceptible to the disorder, but the environmental factors that surround them, or their healthcare behaviors, may trigger this susceptibility. For the causes of developmental disabilities, we're going to talk about where they can occur. because they can occur before a lot of the genetic disorders, the basis we gave to fall into this category. They can happen during the birth process, or they can happen after birth. For prenatal developmental disabilities, some of the causes can include the genetic problems that we've talked briefly about, poor prenatal care by mom, and exposure of the fetus to toxins, including drugs and alcohol, during the development. So some other causes of developmental disabilities that can occur are birth trauma, including hypoxia, and traumatic birth injuries. And sometimes that can occur if the infant does not progress normally through the birth canal. Okay, so in instances where there was precipitous delivery, where the mother may have been a planned C-section and there was trauma to the baby, specifically the head, trying to be forced through a pelvis that could not have that happen, and they end up with subsequent fractures, or worse, and more common is brain bleeds. Okay, some postnatal causes could be malnutrition and child abuse by such means as physical and social deprivation or neglect. So there can be a lot of reasons of postnatal causes for developmental disabilities. So these would be acquired developmental disabilities. When we talk about developmental disabilities, it's really important to talk about newborn screening processes. And that's a state public health service that's offered. It impacts more than 4 million babies a year in the U.S. And it screens for many serious conditions that will allow for treatment before some of the harmful effects can occur. So those are the ones where we do the heel sticks, and the blood spots are gathered on paper and sent away. And the newborn screening also includes a screening for hearing. It's not diagnostic, but it does help us get an idea of if the child may have a hearing problem. Tests are available on more than 60 disorders. It's a screening test. It's not diagnostic. So that means that there will be some false positives and unfortunately some false negatives that do occur. But on the majority, we are successful in screening the newborn babies for any potential genetic disorders that they may have. There's great variability in the number and types of conditions for each state. Because each state determines how many tests are ordered, and it's determined in their public health department. More than 5,000 babies will test positive. About 1 in every 500 to 700 babies have a detectable condition that is picked up in newborn screening. No news is good news for the parents, and that is what we usually tell them, but the results can take about 2 to 3 weeks to get back to the pediatrician. So the pediatrician would get the news from the genetic testing department in the state public health system, and then they have to contact the parents to help with them. And these can come up rather when you're not predicting them, and they can come when you might be taking call for your practice, and you'll get a call saying the baby has tested and been screened for, and they give you the disorder. It may be a disorder that you have to call mom and dad right away because it may necessitate a change in formula if the baby is not able to process or excrete some of the metabolic end products of the digestion of the formula. Then they can build up in the brain, and that necessitates the child to be switched on a different formula immediately. So again, this is something to be prepared of, and definitely if you're taking call for a primary care practice, make sure you ask your collaborating physician if they've ever had that happen, what have been the instructions, to get a better feel for how these newborn screenings could impact your practice. A great place to learn more is www.babiesfirsttest.org. It's really helpful in telling you which states offer which tests too. Why are there variations between the tests, between the states on what they offer? It's impacted by the laws of the state, the financial costs of the screening. So unfortunately, yes, this is a standard of care that is impacted by the state budgets. The frequency of the disorder in the state. There are some states that have higher rates of disorders than others. So that's important to consider also. The availability of the treatments for the condition. There are some conditions that we have no treatment for. So some states will choose not to screen for them. And also the funding sources for the newborn screening program. So they can certainly be impacted on that. Other things to consider too are you can, as a parent, get additional screening done. And that can be done before the baby goes in to the or before mom goes in for delivery. And I have had friends that have gotten additional newborn screening tests done where they bring their special purchased piece of screening, and it looks the same as the little dots that go to the state with the state required screening. And when they get the heel poke, they just put the additional dots, and that is mailed out additionally. So even if you live in a state that it does not have as many newborn testing screens available to you, you can get additional ones. They make a great shower gift too. If you have a friend or loved one who lives in a state that's perhaps testing only 23, 24 newborn conditions, and we happen to live in New York State, which we test the second highest of any state. We're in the 50s. So again, something just to keep in mind. Let's talk about the effect of the developmental stage on the brain structure and function. Not all brains are created equal. Not all brains are created equal in the developmental stage that the child may be in. So there may be intellectual and developmental disabilities, and that's a large class of them that have a neurobiological basis. So again, those are usually the ones that are impacted by the mutational changes. There's changes in structure and function of the brain. This can be significant too if there's been some injury of trauma to the brain. And there can be changes in significance of the disability, and that can vary according to the age of the child and the extent of the insult that occurred, either be it trauma, a genetic disorder that occurred during the formation of the brain and the neurological structures, or how severe it happened in the example of ventricular hemorrhage, if it occurs after the child's already acquired language, or if it has occurred very, very early before that process has occurred. So between the birth and the second year of age is where there's the most significant brain changes and brain growth. Their brains are developing very, very rapidly. Chemical exposures have a really great impact because of the body size difference and the difference. The brains are really big compared to the size of the body. So again, chemical exposures, be it accidental or purposeful at this point, have a huge impact. Their blood-brain barrier is not mature. It's much more permeable. The systems for detoxifying and excreting chemical toxins are not fully developed. So again, that's the liver and the kidney capabilities to excrete these toxins. And over many years' time of exposure or cumulative effects of exposure may impact the overall development of the child. During adolescence, there's many more hormonal changes during puberty that influence their behaviors. And as a mother of 2 adolescents, I can certainly vouch for that. They can be very sensitive, reacting to stress and high levels of stress. And there can be changes in the neuronal circuitry impact in the synapses. So again, how their synapses respond. We're going to talk about some very specific disorders right now, and you'll have to excuse me as I look down to my notes because there's so much information to be able to tell you, and I didn't want to PowerPoint you to death. As far as Down syndrome, we're generally talking about an alteration or mutation on chromosome 21. Okay, and that's 95% of the cases of Down syndrome. The other 5 are caused by a critical part of the chromosome 21 being attached to another chromosome. So the chromosome 21, it itself looks normal, but it adhered or got sticky with another chromosome rather than the entire alteration being impacted on chromosome 21 itself, which generally what happens is when we've got 2 copies or 2 alleles from one parent, 1 copy for the other parent, and all 3 get stuck together within that chromosome 21 versus chromosome 21 attaching to chromosome, the most common ones are chromosome 20 or chromosome 22 in location. But again, there can be some differences of how the child actually, the genetic mutation that occurred to result in Down syndrome. We know advanced maternal age's impact is stronger than advanced paternal age, but advanced paternal age can be a significant factor in the risk factors for Down syndrome, especially when the mother's age is also great, if the mother's also greater than 40 years of age. Although 80% of babies born with this syndrome are born to mothers that are less than 35 years of age. So again, some things to consider. Right now, the incidence is about 1 in 800 to 1,000 of live births that will have this disorder. And again, frequently the disorder occurs during meiosis, so it is genetically impacted. Some of the physical characteristics of Down syndrome is bradycephaly. That's when they have a very short, they have very broad heads. Okay. Some of the other disorders with the hands. Okay. Fifth finger curving is called clinodactyly. So if you do see that. Also, as far as the hands, one of the things that we used to call a simian crease, which is not politically correct anymore, it's now called the single palmar crease. And again, they're very pronounced in the disorders with the children. And again, they go through the hand in that manner. They almost all have intellectual disabilities, though there's a huge spectrum of functioning on that we'll talk about a little bit later, where some actually can function, and these are considered the higher functioning individuals, but they actually function on the low normal range for typically developing human beings. So lax ligaments, we'll talk a little bit about that when we talk about the cervical problems they can have. Their mouth is frequently open. That can occur too because of some of the lax muscle structure through the jaws. They generally are short stature, and they have a widened gap between the first and the second toes. Now, their brains are smaller than expected, than what the typical size brain would be for children of the same developmental age. They do also have some abnormal shaping. They have fewer neurons with altered cortical lamination, so they also have delayed myelinization. And remember that the myelin sheath, the myelinization, is what protects the brain from impact and things like that, and makes sure that the neurochemical changes that occur in the brain occur at the right pace and things like that, as far as protecting any other altering functions out. So the myelinization is a huge issue with this disorder and the difference in the brains. They grow less quickly. Their life expectancy is varied, but on the older end, it's just at about 50 years right now, just slightly less here in the U.S. What is a very good indicator of their life expectancy is their ability to be mobile. So again, those that don't attain the muscle strength or the ligament strength to be mobile, the life expectancy is usually less. Some of the other things that impact our children with Down syndrome are with speech and language. Okay, they have dysarthria, which is a difficulty with articulation, and it has to do with the strength and the precision of the muscles that form the words in the lips. And again, we talked about some of the muscle and the ligament delay, and that's thought of why that they have trouble with pronunciation. Apraxia is the inability to program, combine, and organize and sequence the muscle movements. So again, putting all of those together as far as being able to enunciate clearly and form the words in fluent speech is a problem usually for these kids. They also are known to have expressive and receptive language delays. So understanding can be a problem and expressing can be a problem. And we really like to get them involved in early interventions right away because of communication interventions. Many of these children are taught to sign because they can be proficient in basic signing skills before they're able to articulate speech that's understandable. Some of the other physical health concerns in children with Down syndrome, about 40 to 50% of children with Down syndrome will have congenital heart disorders, be it ventricular disorders. Atrial septal defects are also very common. Also PDAs, patent ductus arteriosus, is very, very common, and about 3% of those of the kids will have that and have surgery while they're right after birth. Gastrointestinal disorders are common. 10% will have problems with obstructions. Esophageal atresia is another big problem, and GERD reflux is significant. They're at risk for Hirschsprung's because of it, which is aganglionic metacolon, and again, having to do with nerve innervation. In the human population, about 0.5 to 1% is at risk for celiac disease, but it's prevalent in about 3 to 7% of Down syndrome children. In Europe, though, about 7 to 16% of the children with Down syndrome have celiac disease there. And again, we don't know and cannot really account for why the increased risk of celiac disease in the Down syndrome children in Europe versus here in the U.S. About 60 to 90% have hearing loss to some extent, and if they don't, as they get older, it significantly increases at a rate that's much higher than the typical individuals. They frequently have tongue abnormalities, and again, I mentioned before that they frequently have an open mouth, and the tongue is usually enlarged, and the musculature of the lower part of the face that keeps the tongue in and the mouth closed doesn't work as well. About 15% will have the atlantoaxial instability, which is an instability of C1, C2, really, really important. And usually what we do is we get C-spine films or tomographs on these kiddos to look at the stability of the C-spines because we really want to be concerned about that before any contact sports. Other issues that are physical issues that are of a concern are increased risk of cataracts, keratoconus. About 75% will have refractive disorders, so many of them have wear glasses. They have an increased risk in leukemias, especially the ALL and AML, and a significant increase in testicular cancer for the males. So again, screening and teaching is going to be very, very important for even the adults with Down syndrome. They're also at risk for obesity and arthritis because of some of the other motor issues and the cervical issues that we talked about. They may not be involved in as many sports, especially contact sports. But again, we really have to, as healthcare providers, promote mobility and sensible eating and things like that because they are at risk for obesity, which again puts huge stress loads on the joints and can cause increased risk of arthritis. Reproductive health issues in children with Down syndrome to consider is there is a decrease for fertility in both males and females. And any female that may become pregnant, many of them miscarry, but there's about a 50% chance that a woman with Down syndrome is going to give birth to a child with Down syndrome. So again, having frank discussions with not only your patient, but your patient's caregivers on reproductive options and concerns. The average age of menopause is about 47, and it's about 49 in those without Downs but with developmental disabilities. And obviously the average age of menopause in typical females is usually somewhere in the 50s, but it can vary with them also. So again, they're going to have reproduction issues for a fairly long period of their life, especially if they have life expectancy near 50. So we really have to start addressing that early. They're frequently put on oral birth controls because they do have an increased rate of premenstrual problems. So a lot of times oral birth control pills will be used to decrease some of the adverse symptoms of that. There are some mental health issues to talk about with Down syndrome also. So they do have more behavioral problems than some of the developmental disorders, but less than some of the others. Okay, and it can vary significantly on their level of intellectual functioning and also their support systems. They can have obviously some behavioral issues. Okay, and they're generally known to have more sleep disorders. So talking about what's a good sleep environment and how to facilitate their best rest for children with Down syndrome. Also, with things to consider with all of this information I just gave you on Down syndrome is to think about how you would modify the health history or the exam that you would typically provide as far as a primary care exam. But again, focusing on some of the history to make sure that we get the best, all the details on some of the issues that may be concerning us as far as early symptoms for some of the disorders that we see associated with Down syndrome. I'm going to talk about Fragile X as another syndrome that we see, another disability. Okay, it's caused by usually a break at the tip of the X chromosome, and it increases the expansion of that mutation for each generation. So again, this is something that we're going to talk about, or we should be talking about, as far as risk for additional generations for the disorder of Fragile X. Some of the prominent features that they may have are a long face, prominent jaws and ears. They have a very high arched palate, which is going to have implications for their dental care and dental hygiene. They generally have flat feet. They have loose joints, and frequently they do have strabismus. So again, we're going to have to consider referrals to ophthalmology frequently. There are both cognitive and behavioral features of Fragile X syndrome. Fragile X syndrome is the most common inherited cause of developmental disabilities for intellectual disabilities. About half the boys have aggression issues and are known to self-injure. So again, really talking frankly with not only our patients with Fragile X, but our caregivers as far as the environment surroundings that they're put in to make sure that they were helpful in assisting them to put the child in the most safe environment, but also safety for the family members and anyone else that may be in contact with them. It's generally a state of hyperarousal, and about 25% of the boys will have autism, will actually have enough autism-like behaviors that they will make the diagnostic criteria for autism. So again, they generally have eye gaze aversions. They have difficulty in social situations. They tend to be very intensely shy. Hyperactivity is not uncommon to see. The social anxiety can be caused by, again, some of the problems with maintaining eye gaze, which is expected in our society. So again, there's some stressors for them involved in that. And again, it's the most common developmental disability, genetic basis of intellectual delay. Some of the special needs of these children would be referrals for behavioral medical therapies for some of the alterations that I mentioned just frequently. They have an increased need for OT and PT for both fine and gross motor delays, so you might want to consider that. As far as the education, frequently they follow guidelines for educational settings for children with autism because they, again, are so sensitive to overstimulation, and many of them have many autistic-like communication features. What a great segue into autism and PDD, which is pervasive developmental delay. This is a very, very diverse group of conditions, and that's why it's really not an illness or a disease process, but more it's a behavioral defined syndrome. And again, the spectrum can be so wide and with so many unique behaviors that it's difficult to put a label on it. The three areas of difficulty that are generally noted in this type of syndrome is reciprocal social interaction and play, verbal and nonverbal communication, and receptive and unusual behavior or of interests. And generally what we're talking about, some of the repetitive interests, which we'll be mentioning. It's much more common in boys. It's 4 to 1 more common in boys than females. And as far as the autism-like disorder, its birth is 1 in 1,000 for autism. It's 3 in 1,000 for pervasive developmental delay. And the reason for that is pervasive developmental delay is a grouping or a classification that we put many of the children that may have a few of the autism like behaviors or delays, but they don't meet all the diagnostic criteria for that group. So again, a lot of them are grouped in the pervasive developmental delay category just because of the inability to define the diagnosis because it's based so individually. It seems to be increasing as far as rates, significantly increasing in Asperger's syndrome, and I really don't know that it's increasing in the population, or we're becoming much more sensitive to it and better at screening. So again, something to consider, but certainly is why it is included in curriculums right now of health providers. We do know that there's a connection between autism and intellectual disabilities, with about 75% of those diagnosed with this syndrome have parallel intellectual disabilities too, and will require special services. This is just a great overview for you to realize some of the things that we're talking about and how they're classified. In one of the later classes, we'll be talking about classifications and documentation as far as medical documentation for these kids, because many of them will have specialized plans, either 504s or IEPs, and we'll talk more about those later, and that you'll have to provide some medical documentation. So this gives you a breakdown of the pervasive developmental disorders and what is classified as an autistic disorder, and which is a non-autistic pervasive developmental delay. Because again, they may have some symptoms, but not all the symptoms to be classified in the autistic group. Remember, it's a spectrum. This is Miss Montana from the most recent of the Miss America, and she has Asperger's syndrome. So again, she is on the spectrum. And again, encouraging patients to realize that this does not have to be a limiting condition, in that just recognizing their communication strengths and weaknesses and making sure they have the resources available. Some of the autism-related goals that you may be helpful to parents in helping them get their correct resources or providing documentation for them are explicit teaching of social and cognitive skills, improving the communication skills. May need to consider other forms of communication, be it sign language, or we also have communication boards where the kids are not able to verbally communicate but can easily use their communication boards to electronically communicate with other people. And positive behavioral support, because again, sometimes we're talking about some adverse behaviors that may not be easy for families to manage in public, outward social situations, but we also have to consider the ones that may be dangerous, either to the child, to the family, or to people unrelated. Remember, one of the classes that I talked about that can be disabilities at birth can be exposure immediately after birth or exposure during the fetal period. And fetal alcohol syndrome is one that we use for an example. It usually requires the presence of 3 features: either growth rate retardation prior to or following birth. They have some degree involvement of CNS abnormalities, and they generally have some facial anomalies that are actually used as characteristics to identify the condition. And this gives you some examples, okay? And unfortunately, though, they can be very, very difficult to diagnose, and we don't diagnose just by the physical characteristics, depending on the culture. Because there are some cultures that may have thinner upper lips, smaller heads, things like that. And it can be more difficult when a culture may have some characteristics of this, and they may have, for other social or economic reasons, higher incidence of fetal alcohol syndrome because of increase in maternal drinking during pregnancy. So again, there's no magic test that can be done for fetal alcohol syndrome. It's usually made on the basis of having a certain number of the physical characteristics, but then also pairing it with the developmental delays that we will also identify through working with the child and family, and usually the school screening system. Risk factors for fetal alcohol syndrome, so how you can help include improve your assessment skills of this, is alcoholism in first-degree relatives, a history of psychiatric disorders. We generally see them coming as far as low socioeconomic status. There can be genetic factors involved, but also increases in the concurrent use of other drugs also. And again, the challenges of the diagnosis. The phenotype can be more easily assessed the older the child gets. And the problem with that is the older the child gets for the diagnosis, the less likely that we were able to implement early intervention for the child to help with some of the developmental disabilities. Some of the physical features can be very similar to other diagnoses. There also can be secondary disabilities involved that sometimes can be greater than the original fetal alcohol syndrome. And there are significant numbers of mental health and behavioral issues involved with fetal alcohol syndrome. And I hope you enjoyed that lecture for today. And I'll look forward to broadcasting our next lecture.